Hi everyone, my name is Stephanie Griffith, and for our session we're going to be talking about the research in fluid management. And I realize this is vast and we only have about 30 minutes, so this will be quick, but hopefully it will be of benefit to you. Thank you so much for joining us today for DRIP, our first fluid management symposium. All right, my disclosures: I am a medical science liaison at Baxter in the Fluid Management Critical Care Division. I am also an assistant nursing professor in Northern California at Simpson University. Our objectives for today's lecture: so we're going to review the pathophysiology of sepsis and septic shock, as well as the physiology of dynamic assessments, review the current literature in the management and treatment of septic shock, specifically as it relates to the cornerstone treatment of sepsis and septic shock, which is fluid management and vasopressors, and then examine approaches in how to personalize care of the septic shock patient using dynamic fluid responsiveness measures and examining best dynamic assessment tests that you can actually use at the bedside. So when we look at the broad overview, and I'm aware that this is an oversimplification of the pathophysiology of sepsis and septic shock, we understand why fluid resuscitation is a cornerstone treatment in the management of sepsis and septic shock, because we have profound intravascular fluid loss. And that volume has to be restored to prevent that circulatory collapse. And we're not going to take it any deeper just for the sake of time, but what I want to remind us about is that the treatment is really predicated on the patho. So treatment's predicated on the pathophysiology of sepsis and septic shock. So then we look at our Surviving Sepsis campaign guidelines that say for patients with sepsis-induced hypoperfusion or septic shock, we suggest that at least 30 mL per kg of IV crystalloid fluid should be given within the first 3 hours of resuscitation. And then we come here to our broad 10,000-foot overview of the most pertinent literature that has been published in the space of sepsis and septic shock over the last roughly 23 years. So when we start at the very beginning, we look to early goal-directed therapy. Let's start there. In 2001, a study published by Dr. Manny Rivers et al. Essentially in this study, this was an emergency department study that had usual care of sepsis and septic shock patients compared to the early goal-directed therapy treatment group. And the early goal-directed therapy treatment group was comprised of fluid resuscitation, vasopressors targeted to MAP, you're giving packed red cells for hematocrit improvement, inotropes, mechanical ventilation, and there were resuscitation endpoints essentially that they were pushing towards, right? Your CVP, your SpO2, certain hematocrit levels, like I said. That also does mean obviously that the patient needs to be lined with more invasive lines. And the reason I'm mentioning that is because then 13 years later, when Process, Promise, and Arise were published, what those studies demonstrated was that compared to usual care, early goal-directed therapy showed no difference in outcomes. So usual care versus early goal-directed therapy was showing no difference in outcomes, whereas in the Rivers study, early goal-directed therapy versus usual care showed a significant mortality benefit. For the reason that some clinicians that I've seen examine this literature really were relieved when Process, Arise, and Promise were published was in part because of resource limited settings that did not have the capability to line every patient, which is what you really needed to be able to get that continuous, SpO2. And I do think that that's worth mentioning because it does make sense that would have brought some relief that, according to usual care, we're actually going to have as good of a benefit if we, fluid resuscitate our patients and give them vasopressors, et cetera, according to usual care. However, because I want to be equitable in my approach toward all of these studies, and because this can be quite a hot topic and very controversial, I do think it's worth mentioning that everyone, regardless of whether or not they're a critic of Process, Arise, and Promise or a critic of early goal-directed therapy. What they can say is that early goal-directed therapy, published in 2001, completely blew the lid off how we treat sepsis, how we're approaching it. The early identification and treatment of sepsis has become the new standard of care. And so because 13 years later, Process, Arise, and Promise were published, patients were already really receiving the benefit and the impact of that change in care because the Surviving Sepsis Campaign guidelines they adopted the early goal-directed therapy treatment guidelines. And so, for example, just one piece of that treatment protocol is to get that fluid on board earlier, for example. So let's talk about fluid for just a minute because they were also getting that basically more attention in the emergency department. And so I would just be remiss if I did not mention the Hawthorne effect when looking at early goal-directed therapy and then Process, Arise, and Promise, because we know that that's a real thing and that the control group is improved as compared with the normal clinical circumstances because of the improvement of care based on the RIVER study. So I think we all understand this, and again, I understand this can be very controversial, but I think one of the things I have heard all clinicians agree on is that the early identification and treatment of sepsis and septic shock really has forever changed for the better because of the RIVER study. So then moving forward, when we look at amount of fluid, if you look across all these studies that I've listed on the screen, on average, just for your knowledge, this is a high-level overview, patients are getting around 2 liters of fluid in a lot of the studies that are published well after RIVER. So there is this idea now that some fluid is needed, and let's go ahead and dive into Classic and Clovers, because with Classic and Clovers, they were examining both a fluid restrictive and a fluid liberal strategy, and essentially did not demonstrate any outcome differences. So we're understanding that some fluid is important, and then now we're also understanding, because of Classic and Clovers, that a one-size-fits-all approach isn't going to work. That's not going to improve mortality. It's not going to improve patient outcomes. So that's one thing to mention there. And again, on average, patients are getting around 2 liters. Why am I mentioning that? So we know that the Surviving Sepsis Campaign guideline recommendations for the weight-based fluid can be modified if the physician is concerned about giving that full amount of weight-based fluid. We've also seen them update being able to use ideal body weight as opposed to actual body weight. And on average, the weight-based fluid is marching out to be around 2 or 3 liters. So those are things to just keep in mind as you're considering protocol development, as you're considering whether or not to implement weight-based fluid strategies in your emergency department. And the reason I keep mentioning emergency department is, of course, because over 80% of sepsis is coming through the ED. So this idea that the early identification and treatment of sepsis is obviously very important, but then also where is that early identification going to happen? And oftentimes it is in the emergency department, just based on the studies. All right, so let's move on to fluid choice. So we've got the split, salt, salted, smart, basics, and plus trials. And the summary, if you just read the abstract, what they'll say is that there was a failure to demonstrate a benefit of using balanced solutions compared to normal saline. So let's walk through a few of these studies so that we can better understand. Because I think if you just look at the broad overview and conclude that fluid choice doesn't matter, then we might actually miss some of the secondary endpoints that would demonstrate actual outcome differences. All right, so let's start with basics, because the patients who were in the ICU were obviously included in the study, so that wasn't what wasn't taken into account was the type of fluid that they received prior to the randomization, so before their ICU admission. So for the 24 hours prior to enrollment in randomization, in the balanced fluid group, 38% of those patients received normal saline before being included into the balanced solution group. So in that study, there really wasn't a direct comparison of patients who only received those balanced solutions, which in this case was Plasmolite, compared to patients who were only receiving normal saline. They were comparing patients who had been fluid resuscitated with normal saline and then given balanced solutions later. So 48% of patients received balanced solutions in the early phase of the normal saline saline group as well. So there was essentially normal saline contamination in both the treatment arm and the usual care group, or the normal saline group, I should say, which is the most common medication that we're giving, at least up until more studies have been published around fluid choice versus more balanced solutions. And the reason I'm mentioning that is because if we're going to say that fluid is a drug, which is really the way medicine is headed, is fluid is drug, and we should be dosing fluid to patient response similar to the way that we dose, insulin to blood glucose kind of a thing, or vasopressors to MAP, for example. Then in the studies, we need to have a pure approach, all normal saline all the way through, all balanced solutions all the way through. If this is going to be further studied, we also hear a lot lately about fluid stewardship, and that is similar to the idea of antibiotic stewardship. So there's some really interesting, we don't have time in this particular session to go into all of those things, but just some fluid for thought, as I would say. So in the secondary analysis of basics, what they found was that patients with just balanced crystalloids before and after randomization, when compared against patients who received normal saline only before and after randomization, also they did demonstrate a mortality benefit in septic patients who only received balanced solutions. So we need to be considering fluid choice that's actually starting in that early fluid resuscitation phase. All right, so let's talk about SMART. So patients that received balanced solutions compared with normal saline in the ICU, they say did not demonstrate a mortality difference. But again, when you dig a little deeper and analyze the patients who received balanced crystalloids prior to the ICU admission against patients who received just normal saline prior to the ICU admission, so before and after, there was a mortality benefit that was demonstrated. So there was a 5% mortality rate decrease in patients who only received balanced crystalloids. So again, that normal saline contamination may be reducing those potential benefits of the balanced crystalloids by the time the patient's in the ICU. So that's just something to consider. Let's talk about PLUS. So again, they were comparing normal saline with Plasmolite. Their conclusion with that was similar to the others, that there was no impact to mortality. But again, 54% of the patients in the Plasmolite group had received normal saline prior to randomization. So I think drilling down to those secondary analyses so that we can really see how the patients were randomized and the fluid that they got prior to that randomization, it's very critically important, because balanced solutions can help. That early phase of resuscitation is obviously where they're going to get the most fluid, because they're getting fluid resuscitated when they're flagged as a sepsis alert or a code sepsis, depending upon how each hospital is implementing their sepsis protocols. So it's just important to highlight the limitations of those studies. I think the next thing to really pay attention to is the fact that Surviving Sepsis Campaign has updated their guidelines to say that for adults with sepsis or septic shock, we suggest using balanced crystalloids instead of normal saline for resuscitation. Why is that? Well, the pH of normal saline is around 5.5, and so there is this idea that perhaps the acidity of normal saline is creating increase in the acid-base disorder, contributing to a hyperchloremic acidosis, right? You've got a pH of LR, which is 6.5, so we're doing a little bit better. And then the pH of Plasmolite's around 7.4, which is more obviously just like normal plasma. So there are other reasons why normal saline may be associated with worse outcomes, including renal artery vasoconstriction, maybe just contributing overall to more inflammation and also hypernatremia. So those things are just some things that are important to consider when you're deciding on fluid choice. So then continuing the conversation, let's remember the Bellamy curve. We obviously understand that there are consequences with both over and under fluid resuscitation. We know that fluids are obviously going to be the most common intervention that we give to treat hypoperfusion, and we understand that we're going to have problems if we do not give our patients a little bit of fluid. What's interesting to note is that according to the literature, fluid overload is actually associated with worse outcomes, and that every single patient does have an individualized volume need. So again, a one-size-fits-all approach is really not ideal. So when you look to sepsis and septic shock patients, your critically ill patients, this has been studied in a variety of different populations, early fluid overload specifically is associated with worse outcomes. So that is something to keep in mind. So then how do we manage fluids after the first initial 3 hours of fluid resuscitation? Surviving Sepsis Campaign updates state, for adults with sepsis or septic shock, we suggest using dynamic measures to guide fluid resuscitation over physical examination or static parameters alone. So that then begs the question, well, what is a dynamic measure, and how did we get here, and why? Well, when you look to the literature, what you're actually going to see is that only 50% of hemodynamically unstable patients are actually going to increase their cardiac output in response to fluid, which means that only 50% of patients may benefit from additional fluid resuscitation after the weight-based fluid. So 50% of the patients will not benefit from additional fluid resuscitation, which is really important to be thinking about. And obviously, when we think about that Frank-Starling curve, what we want when we give fluid is for the ventricles to stretch out and accept the fluid, and for the heart, that snap that we want in the heart to increase the cardiac output, right? We want that increase based on just the normal mechanism of the Frank-Starling mechanism of the heart. What the next question then we need to ask ourselves is, before we dive into what dynamic measures are does using dynamic measures to guide fluid resuscitation in sepsis and septic shock, does this approach change outcomes? And the answer to that may be yes. So I'm going to start with a single center retrospective study. So this was done at the University of Kansas, and essentially they had 200 sepsis and septic shock patients, and there were 100 patients in the usual care group and then 100 patients in the stroke volume guided group. All patients got their weight-based fluid. I just want to point that out. After that point, patients in the usual care group got fluid according to usual care. So oliguria, hypotension, tachycardia, modeling, signs and symptoms of hypoperfusion, high lactate, etc. In the stroke volume guided group, they only got fluid if they were fluid responders. So they would do a dynamic assessment of fluid responsiveness, and those patients would only get fluid if they were fluid responsive. And overall, at the end, when they were analyzing the data, they saw that patients in the stroke volume guided group had on average a reduced fluid balance. You can see reduced ICU length of stay, less time on vasopressors, 32 versus 64 hours. That's pretty significant. Less time being mechanically ventilated, less need for dialysis, 6.25% versus 19.5% of the time, and only half of the patients, incidentally, were fluid responsive. So this idea of using a dynamic measure after the weight-based fluid to determine if a patient is fluid responsive is really becoming a key core topic in the literature and in protocol development and in implementation of care. There's also obviously an economic benefit if you can get your patient out of the ICU earlier as opposed to keeping them in the ICU because of their need, let's say, for mechanical ventilation, CRRT, or vasopressors. The next question then to ask ourselves is, well, can this be done in a prospective trial? So there was a prospective randomized multi-center trial that really, so the KU study formed this hypothesis that was then used in the FRESH study. So fluid response evaluation in sepsis, hypotension, and shock, randomized clinical trial. So the setup was the same. Essentially, you have roughly 200 patients, and everyone gets their weight-based fluid, and then you split the group in half. Half the patients are going to get fluid according to usual care. The other half are going to get fluids only if the patient's a fluid responder. And so I've got the protocol up on the screen for you guys so that you can kind of look through this. Essentially, the clinical decision is made to treat the patient with either fluids and or vasoactive medications whenever the following happened. MAP was less than 65, systolic less than 90, or blood pressure is rapidly trending lower, low urine output, or any other clinical indication to administer or alter fluid boluses or pressors. Vasoactive medication may be de-escalated at the clinician's discretion, but in this protocol, re-escalation should trigger this PLR algorithm because technically that means the patient was hemodynamically unstable, and we know from the literature that only 50% of hemodynamically unstable patients are going to be fluid responders. So you can see they would do a PLR, less than 10% change, meant the patient was not fluid responsive at that time. That's important to note. And then vasopressors were started. If the patient was fluid responsive, then they would get 500 and then reassess. And of course, you can see this would continue down. If they continued to have persistent hypoperfusion, they would get another. They could repeat the fluid bolus. And again, you can see the way that this walked through. And they may initiate or increase the pressor dose if additional fluid bolus volume was greater than 2 liters. So whenever you're asking yourself the question, does my patient need fluids or pressors, it can be really helpful to do a dynamic assessment according to the literature. So let's look at the outcomes. Stroke volume guided fluid resuscitation did result in better outcomes. So there was less need, again, for renal replacement therapy, time on pressors, need for mechanical ventilation. And what's very interesting in the secondary analysis is that more patients were actually likely to be discharged home, which is much better than being diagnosed to a skilled nursing facility. So the interpretation of the FRESH trial is that physiologically informed fluid and vasopressor resuscitation using passive leg raise induced stroke volume change to guide management of septic shock is safe and demonstrated lower net fluid balance and reductions in the risk of renal and respiratory failure. Dynamic assessments to guide fluid administration may improve outcomes for septic shock patients compared with usual care. One of the things I want to mention is that in the PLR group, on average, over 72 hours, patients received around 7 passive leg raises. So this idea of an initial dynamic assessment is great. Let's say you do lactate blood cultures, antibiotics, and weight-based fluid, and then your patient is still hypotensive. So you're not sure at that point if they need more fluid or if they need a pressor, for example. And you do a dynamic assessment of fluid responsiveness and your patient is not fluid responsive. Well, that can be really critical information for you to know. And again, the literature says that only half the time are hemodynamically unstable patients going to be fluid responders. So that's where you're going to see this push for the use of dynamic assessments of fluid responsiveness. So then what should be used as dynamic parameters? Let's walk this through. There can be a little bit of confusion about this, and so I think it's important to just go back to the literature and look at sensitivity and specificity, etc. So surviving sepsis says dynamic parameters include response to a passive leg raise or fluid bolus using stroke volume. So you're looking at stroke volume index percent change in real time in response to doing a PLR or a fluid bolus. That's one way to do a dynamic assessment, I guess 2 ways, a bolus or a PLR. You can look at stroke volume variation, pulse pressure variation, or echocardiography where available. So let's just step back really quick and talk about why we're not doing a leg lift, a passive leg raise, while we're looking at blood pressure. And let's also talk about why we're specifically so interested in stroke volume and cardiac output. All right, this is one of my favorite studies of all time. In 1944, they bled this group of Irish medical students until they fainted. Yes, you heard that right. And we don't bleed people until they faint anymore because it's illegal. But they have replicated this study using lower body negative pressure suits, and the physiology has been the same. So what I want to show you and point out on the screen is that they start bleeding the subjects. They were volunteers. And blood pressure really tries to hang on, right? It really tries to hang on until the subjects faint. Heart rate and our total peripheral resistance is the non-invasive version of systemic vascular resistance. So we see in this study that TPR and heart rate do climb, right? to not only increase what little fluid remains around, that's our heart rate, our compensatory rise in heart rate, and our compensatory rise in SVR, in TPR is normal. We would expect that compensation to be happening in the body. What we see here is that cardiac output is going to fall early. It's going to fall well ahead of blood pressure. So the problem with blood pressure, there's a couple of things just to mention here. The problem with blood pressure is the resilience of it. Our bodies are designed to hang on to blood pressure no matter what. That is literally how our bodies are made. And so by the time our patient is hypotensive, we're already in a crisis. And so that's why we're moving toward looking at what is really coming out of the heart in milliliters per beat, like your stroke volume. Overall cardiac output is also excellent, and some clinicians do prefer to look at cardiac output. I will mention that because the formula for cardiac output is heart rate times stroke volume, when your heart rate climbs, it does mitigate the drop of cardiac output as part of the compensatory mechanism in the body. So that's why you're going to see in a lot of literature looking at stroke volume index percent change in response to a fluid challenge is the most sensitive and specific, because we don't have as much of an impact on actual heart rate. The other thing to mention is, and this is just physics, but it is important to mention, pressure does not equal flow. Pressure doesn't equal flow. And so a blood pressure is different than the forward flow coming out of a patient's heart. And so you cannot do a leg lift and look at the blood pressure and expect there to be a good correlation there. This has been very well studied. We do not have time to go into all of that again in this particular lecture, but I do want to mention that. So let's talk about dynamic assessments then in order of ease, accuracy, sensitivity, and specificity, all of those things. So a passive leg raise is when you sit your patient up in bed and essentially the blood drains from the torso down to the lower extremities. The calf veins of the legs are where a lot of that blood is going to pool, and you're looking at a stroke volume index, let's say continuously. Okay. This is a positional test. Molly, one of my ICU educators, says this is the only bolus you can take back. And I absolutely love that, because essentially you set your patient up, you look at stroke volume index continuously for a few minutes, and then you lay the patient back, passively raise their legs. They cannot help you. That would increase their venous return, obviously. And the blood will rush from the legs up through the IVC and hit the heart. And studies demonstrate that a lot of times patients will actually hit their maximum stroke volume index in about 90 seconds. Some patients it takes longer, but the idea is that if you get a baseline stroke volume index and then you challenge the heart with a little bit of fluid, according to the literature, a stroke volume index climb of 10% or more means your patient is likely to increase their cardiac output in response to further fluid, specifically in response to around 500 cc's of fluid. That's why you'll often see in the literature or in protocols that are published to give a fluid responsive patient 500 mils of fluid. That's where this kind of comes from. An IV bolus is, the entire point of an IV bolus is that it can be done in patients regardless of the position that they're in. They can be prone, they can be in a chair. So that's nice for ease of use, especially in the emergency department. But the entire point of an IV bolus is to mimic the physiology of a PLR. That's why 250 cc's has to get in the patient in 5 minutes or less. And that's why 500 has to get in 10 minutes or less, because what you're really trying to do with dynamic assessments is interrogate that Frank-Starling mechanism of the heart, which means the fluid has to hit hard and fast. For PPV and SVV, these are respiratory-based parameters that require the respiratory cycle, essentially, right? Our big, just taking a big breath reminds us of this functionality of the heart-lung relationship. And in order for PPV and SVV to be accurate, very, very specific criteria have to be met. Now, PPV, technically, if you want to look up sensitivity and specificity, is more accurate than SVV because PPV is not a derived calculation. It's more direct. I'm not going to go into all of that per se, but what I do want to mention is that your patients do need to be intubated. side. They do need to be in a normal sinus rhythm. So we see most of the time in our septic shock patients a lot of AFib with RVR. So that's why this can be a little bit challenging to implement in clinical practice. They also need to be breathing very high tidal volumes, 8 to 10 milliliters per kg. So let's talk very briefly about a tidal volume challenge, which does demonstrate good sensitivity and specificity. Now, a nurse can't do this, so that's important to note. Nurses don't usually adjust ventilator settings. In our ICU, we were not allowed to do that. But as the provider, if you wanted to do a tidal volume challenge, there's some good literature around doing that very briefly at the bedside to determine if your patient is a fluid responder, provided they meet all the other criteria, normal sinus rhythm, etc. They also need to be breathing identical breaths. So you can see how SVV and PPV can be really great, but challenging for clinicians to implement in clinical practice in terms of a strategy widely applied for dynamic assessments, because if your patients aren't intubated, they automatically are disqualified. If your patients are in an arrhythmia, they're disqualified. So those are just important that they work. They're good when you meet the criteria, but you do need to understand the limitations, obviously, in order for that accuracy component to be able to come forward. Let's talk briefly about echo. So echo as in an echocardiogram. You can look at the left ventricular outflow tract. You can actually do a passive leg raise while you're doing an echo. Have the patient sitting up. Again, you measure, and then you lay the patient back, passively raise their legs, and then you can actually look at the changes. I don't, for the sake of time, have time to go into this, although if you're interested, we can certainly do a follow-up lecture on how to actually do this. Echo is critical information, especially when we're worried about structural heart, and I'm going to talk about that a little bit later. But it can absolutely be done. What I do want to say, and I won't have time to go into this now, is that this echocardiography is different than the IVC collapsibility, which is technically different than a dynamic assessment. Helpful when your IVC collapsibility, I think, is helpful when you're doing a quick wet to dry, are they really fluid overloaded or are they really volume depleted? But technically, according to the literature, IVC collapsibility is not considered a dynamic assessment of fluid responsiveness, which is just important to know. A PLR is going to be the most useful test for predicting fluid responsiveness in your hemodynamically unstable adults. Again, very high sensitivity and specificity. It's nice because patients can be spontaneously breathing. I've also done it in intubated patients. So this is predicated on the fact that the patient can tolerate a positional change and that they don't have a groin line that would be compromised. So there are some limitations. Again, all tests would have limitations. In those instances, if I were able to look at stroke volume index continuously, I would do a fluid bolus as opposed to a PLR. But again, like Molly says, it is a bolus you can take back, which is great. I just wanted to show you an example. This is from a paper in the Cardiothoracic Journal of a PLR protocol with a septic patient with refractory hypotension. So after the weight-based fluid, we're still hypotensive, and you can see just a very simple treatment algorithm of just implementing a PLR fluid assessment. Less than 10%, not fluid responsive. After the weight-based fluid, we'll start a pressor. If they are fluid responsive, we'll consider fluid resuscitation. I think one of the things that's important to note in all of this literature as we examine it is that a dynamic assessment of fluid responsiveness result does not tell you what to give. It doesn't tell you what the patient needs. It also doesn't tell you how much to give. So that decision needs to be handled by the provider. So the physician or your NP or your PA is going to be the one saying, oh, the patient got their weight-based fluid. This is their entire clinical history. I'm going to zoom out and look at the full clinical picture. They are or aren't fluid responsive, and then make those interventional decisions accordingly. Let's talk really briefly about early vasopressors. I am aware that this is fraught with tension and conversation. I've had some great conversations with ED docs around the literature that's being published in this space, but also the stress of it, because it does change, obviously, the acuity of the patients, and that is just an important thing to note, that there are some hospitals now implementing specifically ICU beds in their emergency departments in order just to deal with sepsis and septic shock, as well as creating sepsis-focused nurses in the ED or sepsis nurses in the hospital that respond to all code sepses or code similar to like a rapid response team, only they're sepsis only focused. I'm seeing that done more and more on the West Coast. I'm on the West Coast, but this paper from Dr. Sanchez et al. Was published this summer. And one of the things that they were saying in the beginning of their abstract was that obviously the current recommendation of the Surviving Sepsis Campaign guidelines is to give that weight-based fluid, but there are some patients where that cannot be applied. It just can't be applied to all patients, depending upon what they're walking in with, right? Your CHFers may be your COPDers, your acute kidney injury patients, or your chronic kidney patients. And so we know that, and they mention this in the article, that there are complications with over and under fluid resuscitation. We already looked at that with the Bellamy curve. And we know that we could further delay organ recovery and then prolong ICU length of stay, mortality, and that's an issue. They also remind us in the paper that the only reason to administer IV fluids in a patient with circulatory shock is to increase the mean systemic filling pressure. I'm directly quoting from their article, in a patient who is volume responsive such that cardiac output also increases. And then they say this: based on current evidence, the very early use of norepinephrine and its combination with smaller amounts of IV fluids in fluid responsive hypotensive septic shock patients does seem to be a safe strategy with better management results compared to large volume fluids before vasopressor initiation. So they're saying vasopressors should be initiated as soon as possible in patients with septic shock. And that is also why clinicians are seeing an increase in peripheral vasopressor protocol development because of the literature that's coming out. Dr. Monet et al. Also published a great paper on this subject as well. And the reason these two, this is me editorializing, in my clinical opinion as well, is because they are summarizing a vast amount of literature in this particular space. It might be worth reading, but they are reminding us that duration and depth of hypotension are very strongly associated with poor outcomes in septic shock, and that volume expansion may induce variable responses in arterial pressure. That's a direct quote. First, because its effects on stroke volume are inconsistent, they say, delayed, and transitory. And second, because of a phenomenon that we're all aware of, which is the arterial elastance, which is obviously going to determine the relationship between the fluid-induced changes in flow and arterial pressure. So we know that that's going to be variable. They say in the case of profound life-threatening hypotension, relying on fluids, only on fluids, to restore to restore blood pressure may unduly prolong hypotension and consequently organ hypoperfusion. So again, they're saying early administration of norepinephrine should also be considered in patients in whom fluid accumulation is likely to occur, or in whom fluid accumulation would be particularly deleterious, again, in case of acute respiratory distress syndrome or intra-abdominal hypertension, for example. I like that they included those patient populations as well. This is what they go on to say. Conversely, norepinephrine rapidly increases arterial pressure, its dose being adjusted accordingly to the arterial pressure target, which we're aware of. Logically, it should first be addressed to patients with profound hypotension when the arterial tone is very low, as suggested by a low diastolic pressure, or by a high diastolic shock index, which is your heart rate over your diastolic blood pressure, which is something else that we don't have time to talk about, diastolic shock index, in this particular lecture. I want to end by going back to the Sanchez paper with a nice summary. Perhaps all these strategies are appropriate, as long as the fluid therapy is personalized, as something that seems as simple as administering fluids can become a very complex process with catastrophic consequences for the patient when it is not done correctly. It is prudent to determine beforehand the volume responsiveness in a patient with shock. As we close out this lecture, I want to remind us, as we think about the literature and think about treatment choices, the goal is obviously to maximize oxygen delivery in our patient. And this is an oversimplification of the oxygen delivery sort of equation. But I want to talk through this because arguably there's a lot that we can do especially as nurses. And the reason I'm mentioning that is because nurse-driven protocols can be implemented on a broader basis than other protocols with dynamic assessments that are provider dependent, which is one reason why many hospitals are trying to find different ways to implement dynamic assessments that can be nurse-driven. Okay, we'll come back to that actually at the very end. I'm assuming when we think about the oxygen delivery equation and what I'm about to say, I will be focusing on stroke volume. I'm assuming if your patient's bleeding, you're handling it, and I'm assuming if your patient is, dropping their SAT or they need to be tubed, or that you're handling it, okay, or that you're adjusting ventilator settings, etc. On the left side of the oxygen delivery equation, when we look at cardiac output, we know the formula for cardiac output is heart rate times stroke volume. I'm also assuming if your patient is in some wicked rhythm that you are handling that. And so I'm not going to go into rate and rhythm. We're going to focus on stroke volume, which is comprised of preload, afterload, and contractility all working in concert together. And I was taught this idea of pulling a lever in the body like a lever on a slot machine, this idea that when our patient presents to us with a perfusion deficit, if we go all the way back to the very beginning of the lecture, like hypotension, tachycardia, oliguria, modeling, any sign or symptom of hypoperfusion, maybe even adding a second pressor or titrating up on our norepi, for example, then we have this opportunity to essentially pull 3 levers of perfusion in the body. And I worked with just fantastic nurse educators, Karen and a physician, Doug Hansel, that helped me with understanding this idea of pulling a lever and doing a thing. And then I added a little bit more flavor to it, just to also help us understand the hemodynamics at the bedside. Why am I telling you all of this? Because I'm a nurse educator, and because I work with new grads, and because over 90% of in-person clinicals were canceled during COVID in the state of California alone. And so one of the things, as we look to the literature and as we look to the as we look to the research, we then have to take that back to our new grads. We have to take that back and elevate the bedside understanding so that we can have better conversations with our providers, and so that we can be more informed as to what we're actually doing instead of being task focused. Really zoom out and look at the clinical picture. So please feel free to use this if it's helpful to you to teach your nurses. I'm going to go through it pretty quickly, but you will get a replay of this, and I'm always happy to answer any questions. So when our patient presents to us with a perfusion deficit, we can pull the preload lever. Preload is obviously the amount of volume sitting in the ventricle prior to each beat. We look at preload by looking at stroke volume and stroke volume index. I'm aware that this is a gross oversimplification, and if you're a cardiologist, you might have an issue with what I'm saying a little bit. Totally fair. But I am trying to simplify also for the sake of time. I want you to remember V for volume. Remember that a normal heart rate range is the same as a normal stroke volume, and roughly half that is your normal stroke volume index. So I can pull the preload lever and I can give my patient fluid. But after that weight-based fluid, we need to remember that only 50% of hemodynamically unstable patients are actually going to be fluid responders. So we want to go ahead and do a dynamic assessment of fluid responsiveness prior to giving additional fluid at that time. Now, if our patient, whether or not they're a fluid responder, this is what we're often asking ourselves is, well, do they need fluid or do they need a vasopressor? And we just went through a lot of literature that was talking about this. So afterload is working with downstream blood flow, and it is the amount of resistance the heart has to overcome to get blood out to the body. So you can measure this invasively or non-invasively. Total peripheral resistance is the non-invasive version of SVR. It removes CVP from the equation, thus enabling you to actually not have to have a line for the patient, which is nice. I like to remember R for resistance, and your normal values are on the screen. What's important to remember here is that the lower the number, the more vasodilated the patient is, and the higher the number, the more vasoconstricted they are. And so because afterload and cardiac output have an inverse relationship, when you are titrating your pressors or you can't wean the levofed on your patient, it can be really helpful to do a dynamic assessment of fluid responsiveness to determine, well, does my patient actually need more fluid, or do they need this much of a vasopressor? So our third lever of perfusion that we can pull when our patient presents to us with a perfusion deficit is contractility. And sometimes when we pull the contractility lever, we're giving fluid, and sometimes we're giving an inotrope. And if your cardiac index is low, especially if the patient has gotten fluid, this is the time to slow down and get curious and ask more questions. This is the time often when I will see that provider needing an echo. Do they need an inotrope? I don't know. Do they need a full cardiac workup? I don't know. Do they need an echo? Probably. There was a small study that I am going to mention that showed that if a patient, there were 11 patients in the FRESH study that had a negative percent change. I'm aware this is very small, but I do think it's worth mentioning, and that further research is needed. But the higher the negative, the greater the degree of cardiac dysfunction. So a negative number, so not only did they not climb from a baseline in the 0 to 10% range, they actually had worsening cardiac function when the heart had more fluid introduced to it. And so there could be a signal there of cardiac dysfunction. Using a dynamic assessment, potentially, it does need more studies are warranted here, but that could be good information that you would want to pass on to your provider if you're a nurse, or if you were a provider, if you got a negative number reported to you by your nurse, that you might actually want to follow up with an echo. So again, a lot of complementary technologies, I think, using bedside ultrasound can be very helpful here. I like to color code the cardiac output monitors, so I turn stroke volume index numbers blue, and I think blue like water. This helps when you're teaching new grads the principles of hemodynamics. Okay, we're going to remember stroke volume, V for volume, blue like water. I also like to turn the TPRI purple, and I think purple for pressor. I know it's silly, but again, when you are faced with values that maybe you're not overly familiar with, even though it's becoming more common to be doing dynamic assessments, it can still be overwhelming when we're in the beginning of learning anything. So I try to simplify it and make it easy. So purple for pressor, and then contractility is very silly. I think I turn the cardiac index yellow because we squeeze a lemon. And I find that is very helpful when I am teaching. So maybe those tools will be helpful for you. I wanted to just end talking about a management theorist, Peter Drucker. He says what gets measured gets improved, and I believe some of my colleagues might also say this as well. But on the HR Director website, which is just a fantastic website, they are talking about management principles, but I think they apply to medicine as well, and I wanted to end with this. They say this: the trick is to understand the value of the data, to measure the right things, and then make sense of it all to inform your decisions. And I think that's really what we're trying to do here with dynamic assessments of fluid responsiveness, with fluid choice, is gather that data and actually inform better decisions at the bedside. And later on today, you're going to hear how you can actually do that using innovative principles and technologies. And then if you want to implement a fluid management program at your institution or a protocol, what are some of those best practices that can actually help guide you? So thank you so much for your time. And please email with any questions. I would love to hear from you and answer your questions.